Just start talking? Okay. All right. Well, good morning. My name is Dr. Milton. I'm currently the Chief Medical Officer for Emory Rehab Hospital, where I'm the Medical Director of the Brain Injury and Stroke Unit. And it gives me great pleasure to introduce Dr. Noble Jones. Dr. Jones and we met over the summer. And quite frankly, he was introduced to me by another colleague, Dr. Khanna, who said, I know a good guy who may be a good fit for you. So we met over the summer, we talked several times, and I knew immediately he was my guy. Didn't even read the resume because I didn't have to. However, in preparing for this talk, I actually read the resume and I'm astounded at what I read. I just needed to know I just needed to know that I was hiring a person who was compassionate, cared about his patients, and had a love for providing care. Um, However, what I did learn is that he went to Purdue University, where he studied mechanical engineering. From my experience, engineering is probably one of the most rigorous bachelor's programs you can do. However, he found time to be a four-year letterman on the varsity football team for Purdue and also earn all Big Ten academic honors while being a scholarship athlete, as well as earning his varsity letter. From there, he went to school to gain his master's in mechanical and system engineering at Johns Hopkins. While he was in med school at Case Western Reserve, he was also performed biomechanical engineering research, as well as working with the NASA Glenn Research Center, testing respiratory medical equipment for the use of astronauts during space exploration, and also looking into problematic simulation to mitigate the negative effects of unplanned human medical events on spaceflight missions. He also worked as a lead mechanical engineer and systems engineer for the NASA Goddard Spaceflight Center, where he also won an Exceptional Achievement Award of medal. After he completed his med school, he was an intern at Duke University and then completed his physical medicine and rehabilitation program at Kessler Institute at Rutgers in conjunction with Rutgers in New Jersey. He completed a fellowship in cancer rehabilitation at Kessler as well. And he's also been published in peer-reviewed articles more recently in November of 2022, where he studied radiation plexopathies and evaluation and management of radiation-induced plexopathies. He has won an award for the Best Quality Improvement Group Project for acute care transfers prediction tool. He was involved in the community where he volunteered at Walter Reed Hospital. The family's from DC. I know that hospital very well, and at the Washington Hospital Center. He is a member of the American Academy of Physical Medicine, Pan-African Academy of Christian Surgeons, Christian Medical and Dentistry Association, and Society of GI and Endoscopic Surgeons. Currently, he's our program director for inpatient oncology rehab at Emory Rehab Hospital, where he also serves for the School of Medicine as assistant professor of rehab medicine. I'm humbled to introduce you to Dr. Noble Jones, who will be presenting today. Thank you, Dr. Jones.
Thank you. Thank you. All right. Good morning, everyone. Thanks for that introduction, Dr. Milton. So today, the topic is going to be long-term complications in breast cancer patients. And the way I like to learn is to actually use a real patient case to kind of walk through and teaching points along the way. So I'm in outpatient clinic over in one of our outpatient centers, and I have a patient who had a history of breast cancer who was referred to me. And she came in and her chief complaint was left shoulder pain and immediately requesting, I need a steroid shot. So I'm considering all of this, her history, but I want to get to the bottom of, does she really need a steroid shot? So let's look at the symptoms. She said her shoulder pain started 6 months ago. She also complained of some left chest wall pain that she described as sharp stabbing, aching, burning. She had some restriction in her range of motion. She had some weakness in her upper left extremity. She also had some functional impairment. She dropped things a lot when she was, picking up small objects. Incidentally, she had a cut on her thumb, and didn't even know it because she had decreased sensation. She had unusual itching, difficulties again with the fine motor tasks, and then even bending her arm or lifting it exacerbates pins and needle sensation. Additionally, her left arm feels heavier than her right. So before jumping into the physical exam, anytime you have a patient with a cancer history, it's always important to go and look at her oncologic history. So, and this is for any practitioner, regardless of what the chief complaint is. So, looking at her cancer history, uh, in January of 2021, she had a self palpated breast mass that was later evaluated more with a biopsy and found a grade 2 ER/PR positive invasive ductal cell carcinoma. MRI of the breast showed that she had a 7.2 centimeter mass in the left upper inner quadrant. PET scan later that month showed no evidence of metastasis. She underwent neoadjuvant chemotherapy with adriamycin, cytoxan, and paclitaxel. And then the next month, she had genetic studies done to show she was BRCA2 positive. So she underwent later that year, and in June, a bilateral skin-sparing mastectomy with axillary dissection and tissue expander reconstruction or expanders placed at the time of surgery. She was then underwent adjuvant radiation therapy. She had 50 gray total to the left chest wall, 14 gray total to the supraclavicular region, and 10 gray to the left axillary region. And all this was spread out over several weeks. Later, she also underwent bilateral salpingo-oophorectomy. She declined endocrine therapy because she was having such a difficult time with the treatment, with the chemotherapy. There were times where she stopped chemotherapy because she couldn't tolerate it well. So she was psychologically and physiologically going through a lot at this time. So she declined any further endocrine therapy. There was a recommendation to start exemestane, which is an aromatase inhibitor, as well as Verzenio or Lynparza, which are they're checkpoint inhibitors. I believe that's not accurate. Actually, not checkpoint inhibitors. They are. You know what? I'm drawing a blank on that, on their mechanism of action. What's that? Oh, that's right. PARP inhibitor. That's exactly. So I'm not an oncologist, but I treat the patients. So we're still part of the team, and that's fine. Thank you for your help. So she had a difficult course. She was still going through a lot of the side effects, weight gain, some cognitive deficits from the chemotherapy. And then a couple of years later, when she thought everything was okay and she was returning back to her normal life as a esthetician, she started developing pain and sensory changes in the left arm. That began in October of last year. She described her symptoms as tightness in the back that evolved into a constant pins and needles sensation radiating down the arm. And it involved the left first three fingers, thumb, pointing finger, middle finger. And then numbness in the forearm, unusual itching sensation in the arm, and diffuse pain from the neck down. She had difficulty, again, with the fine motor skills, and these are the symptoms that I discussed earlier. So it's time for the physical exam. And in my head, now I'm thinking, is this more than just your typical arthritic shoulder or rotator cuff injury? Just giving her history alone and her symptoms. So on exam, she had an erythematous, well-demarcated, rectangular-shaped area of skin on her left chest wall. And she said that was due to wearing a lidocaine patch that she was wearing for pain. She was having what looked like a dermatologic response. She had some swelling on the dorsal surface of her hand, her forearm, and upper arm on the left side. So it was slightly larger than the right, but there was no visible atrophy. There was no scapular winging in the medial or lateral. There was no medial or lateral scapular winging. On palpation of the left upper arm, there were some nodules in the left axillary region that were palpable. Active range of motion was very pain limited. Abduction was reduced to 70 degrees against gravity, flexion reduced to 120 degrees against gravity, but with passive range of motion and neutralizing gravity, we were actually able to achieve full range of motion. Sensory, segmental dermatomes were intact, C5, C6, C7, C8, and T1. And then peripherally, the axillary, mucocutaneous, radial, median, and ulnar sensory innervations seem to be intact as well. So, interesting thing about this patient, she also presented with her left pupil smaller than the right, and it wasn't responsive to light. Motor strength exam, manual motor testing, she was 5 out of 5 on her right arm, which was expected because that was not the arm that had chief complaint. But she was 4 out of 5 for elbow flexors and shoulder abductors. That's the C5 distribution. Reflex exam, she was hyporeflexic, biceps, triceps, and brachioradialis on the left side, but 3 out of 3 plus on the right. So she was hyper on the right, slightly hyper. So differential diagnosis. Possibility, sure, rotator cuff tendonitis. That's always a possibility, and it's not even excluded from this exam. However, osteoarthritis, lymphedema of the left arm, could that be causing her issue? Could we have metastatic disease? Like up until the point of our exam, there was no confirmed evidence of recurrence. Brachial plexopathy, and I'll get to more why that could be as well. Pectoralis minor syndrome as a side effect from her surgeries. Could she have radiation-induced fibrosis of the chest wall, and that's causing, because that's a progressive process? Or is there radiation-induced degenerative joint disease of the shoulder? Something else we'll discuss in a little bit. And additionally, chemotherapy-induced peripheral neuropathy. So she could have one or a combination of all of these as the cause for her symptoms. So let's revisit her treatment history. So for the surgery, she had a bilateral mastectomy with axillary dissection and expanders placed. And then later, she actually underwent the reconstruction, had complications from that, which I didn't discuss earlier, but she had to have the breast reconstruction, implants removed after developing capsular contracture, which we'll discuss later. And she underwent a deep flap surgery procedure. She also had bilateral salpingo oophorectomy. So those are all her oncologic related surgeries. Radiation to the left chest wall, left axillary region. And these are the systemic therapies. Now she declined the treatment for exemestane, Verzenio, and Lynparza, but I listed it because these are still good teaching points for us. So let's talk about the bilateral skin sparing mastectomy. So typically in general, there are 4 basic, not basic, but 4 types of surgery that a breast cancer patient may undergo. They may undergo a simple mastectomy or a modified radical mastectomy, where they remove all of the breast, as well as the nipple and some axillary nodes. You also have skin sparing, where they actually spare the skin around, and you have nipple sparing, where they spare the skin as well as the nipple. Now, the lymph nodes that are dissected, they're often removed for, not all, but many of them are removed for further evaluation to see if there is metastatic disease or if the tumor has invaded the tissue or the circular lymphatic system leaving the breast. But you can have complications even from just the surgery alone. You could get post-surgical scarring. Some people scarred a keloid They have difficulty that can cause a restriction in shoulder pain. Um, she underwent radiation. So this is an example of radiation dermatitis. And the skin is injured, damaged from the radiation treatment. Or she could go undergo axillary cording. This could be secondary to the effects of the lymph node dissection, where now the lymph circulation is compromised. And these patients often get a very, very painful tight cording that requires therapy to resolve. And oftentimes it can recur. She underwent breast implantation. This is an image that shows where the implant is implanted underneath the pectoralis major versus over the top of it. Now, she underwent radiation therapy. And so one of the things that we're going to talk about in a bit is that radiation therapy, although is very instrumental in killing the cancer cells, there's a progressive chronic response that our bodies have to radiation. My mentor used to, Dr. Stubblefield, where I trained, used to say it's the gift that keeps on giving, because oftentimes this muscle or the vascular tissue or the skin would continue to have a recurrent, not a recurrent, but a perpetual fibrosis where the fibroblasts are depositing extracellular matrix. So those muscles can get tighter and tighter, and they can put the nerves in traction. As you can see here, this is an example of an implant. This is the normal size. If the capsule that's underneath or the capsule around the implant or the tissue starts to contract, you can see that can make it tighter and tighter and smaller. That can be very painful for the patient. And so this is just an example that shows that this patient here on the top row or the top, she had the implant implanted outside of the pectoralis muscle, whereas this patient or this side shows after the fact where you have contracture causing deformation in the actual breast itself. So this scarring or this fibrotic process is a normal process. It happens regardless of the radiation. But radiation can make it worse. It can make those leukocytes infiltrate and the fibroblasts proliferate continuously around the breast and the implant, causing this contracture that squeezes and hardens. And the patients usually experiences pain and tenderness, the breast shape deforms, and this happens over time. In our patient, she had the implants placed, but within about 12 to 15 months, she couldn't tolerate the pain anymore, had to undergo a second surgery just to have the implants removed to undergo another breast reconstruction procedure. So, you know, we often, at least in this field, we talk about breast post-mastectomy pain syndrome, and our patient was experiencing that, but another way probably is more accurate to describe is post-breast surgery pain syndrome, because any breast surgery in this setting can cause pain, whether it's a mastectomy or a lumpectomy. The radiation compounds the effect of what the patients experience. And the primary mechanism is this intercostal brachial nerve injury during the surgery that can cause a neuropathic pain. And then there's a central sensitization from persistent nociceptive input. So after a while, the pain is so much that it almost becomes impossible to resolve. Secondary contributors, we talked about radiation, scar tissue, neuromas can form. And then there are psychological factors as well, the anxiety and depression. Depression can amplify pain as well, or at least the perception of it. So here's some isodose curves of radiation treatment on a patient. So this patient is getting, in this position, you can see there's the radiation beam is irradiating the axillary region. But notice all the other structures that are in the field of view. Here you have the heart, You have the lungs, part of the lungs. You also have, again, the lymph nodes in this region, which have been dissected and the circulation is compromised. You have the brachial plexus. You have the pectoral muscles. You even have the shoulder joint. There's another view, but you have the shoulder joint as well. And all of these structures, once they're subjected to repetitive radiation or any amount, they are susceptible to degradation and eventual problems in a patient later. Examples, you can develop fibrotic pulmonary fibrosis. You can have radiation induced degenerative joint disease in the shoulder. You could have weakness, scarring in the muscle tissue. Again, this is a perpetual, chronically progressive process where these fibroblasts are just continuously to deposit extracellular matrix, and it's an inflammatory cascade that's turned on and won't be turned off. This can put the brachial plexus in traction as well, which causes the sensation changes in the arm in different distributions. And again, this is just an example of one patient. So then let's talk about those radiation-induced plexopathy. So it can be not only radiation induced, but it can also be a sign that there may be tumor progression in that region. This just showing an image of the brachial plexus here as it enters to the right above the supraclavicular region. So the radiation has a toxic effect on the axons and the vasa nervorum, and that causes microinfarcts and nerve injury. And the degree of toxicity really depends on the radiation received, not only the total dose, but also the fractional dose. So there are studies that show if you stay under 2 gray per fraction, you can mitigate the harmful effects of radiation on the nerve tissue or the brachial plexus. The symptoms can develop or start within 6 months, but it can be up to 20 years. Again, this is a chronically progressive process that's occurring. Additionally, chemotherapy, neurotoxins can also increase the effects of this post-radiation plexopathy. So we also talked about the DEEP flap procedure, the deep inferior epigastric perforator. So for those who are not completely familiar, the tissue here in the lower abdomen is removed, and it's replacing the breast tissue that was removed during a mastectomy. Our patient had a bilateral mastectomy, so she actually underwent a deep flap reconstruction on both breasts, and they leave the vasculature intact so that the tissue itself can be perfused once it's implanted, and then the incision is closed. But from a musculoskeletal perspective, I mean, there's wound healing difficulty, not only here, but also in the irradiated tissue. That's a difficulty or a challenge for the patient. So maintaining that blood supply is important. And then also there's just a psychological effect that this patient had to undergo yet another surgery. So we talked about the radiation therapy. She got it to the left wall, the left axillary region, and that's also where she had lymph nodes dissected. Again, you have the initial exposure, you have fibroblasts, you have cytokines, macrophages. All these things are activated, and it becomes inflammatory, and it just turns into this perpetual process where the extracellular matrix and collagen is deposited. It's just a response of the body, but it just is continuous. And it is the gift that keeps on giving. So this patient had the radiation to her axillary region. So when that happens, that increases your risk of lymphedema. Again, the dissection itself alone compromises the lymphatic circulatory system. But now you have the added insult of radiation. And so now you have the vasculature the soft tissue, all of it is having this extracellular matrix deposited, compromising the circulation even more. Now, remember I told you earlier that she had a cut on her thumb that she didn't feel because she had sensation deficits. And she had a patch over her left chest wall. And it looked like there was like an inflammatory response to that. So anytime you have anything that breaks the skin and increases the risk of an infection in a limb that has had the lymph nodes dissected and removed, now you have risk for lymphedema developing. So it's very, very important for these patients to manage their skin care, limit infections, bug bites, skin abrasions, even surgeries. Oftentimes a patient comes in with surgery, a shoulder pain, and they are referred to orthopedics, and they may undergo some type of surgery procedure just to repair what is the perceived problem. But that sets the patient up for developing lymphedema. And so you have the different stages. Actually, that's inaccurate. It should be stage 0 through 3 here. But when you get to stage 0 and 1, it can be reversed. It can resolve with compression therapy, however, and also lymphedema therapy, decongestive therapy with lymphedema therapists. But once you get to stage, which should be 2 and 3, it becomes irreversible. But that does not mean you don't continue to treat the patient. You should continue to treat the patient, because if you don't, it will still progressively get worse. So let's talk about the systemic therapy. Adriamycin, Cytoxan, Taxol, they all have acute side effects. Very familiar with the nausea, vomiting, hair loss, sores, myelosuppression. There's also the chronic long-term organ system effects, cardiotoxicity for the adriamycin, secondary cancers like leukemia, myelodysplastic syndrome, amenorrhea in women over the age of 40, but it actually can cause early onset menopause in all women. Cognitive changes, chemo brain is a real thing. So a lot of these patients also need neuropsych or speech and cog therapies as well. There are bladder cancers that can also result as a chronic long-term side effect from Cytoxan, pulmonary fibrosis, Taxol, very well known for causing persistent neuropathy that we have to use neuromodulating agents to treat. And then just chronic pain syndrome once that pain becomes centralized. And then you have radiation recall errors, which radiation typically causes the dermatitis, like at the acute onset, but you can also have skin changes that become chronic and recur later. And then you have also possible lung damage, which is pneumonitis. And we saw in that last image, or the previous image, where the field of view of that radiation beam was actually causing potential damage to the lung tissue in the upper lobes. And then now we also have some of the hormone therapies. Well, one of the hormones, all of the hormone therapies actually can cause hot flashes, joint, muscle pain, fatigue. Again, once you start blocking estrogen, then it can cause an early onset symptoms of menopause. Osteoporosis, fractures, high risk for the chronic long-term, cardiovascular risk, cognitive changes. And then for the other agents, Verzenio or Lynparza, they can cause anemia, fatigue. Again, a lot of these things are overlapping in what they can cause in terms of chronic effects. But when you have a patient who's potentially taking all of these, then it compounds. But it's necessary to treat. It's just we have to be aware of it on the long-term side, on the long-term follow-up. Then there are the neuromuscular skeletal effects. So all of those are more organ system, but then we still have bone marrow suppression, muscle spasms, rhabdomyolysis, muscle atrophy. Again, and even Taxol showed that myalgia occurs in 60 to 70% of patients. A lot of neuropathy from the Taxols as well. And then very similar for the other agents as well. So again, all of these things, understanding the patient's history, understanding the cancer treatments that they have received will help you diagnose, the etiology of the current chief complaint. And so what can we do about it? Well, you can send them to oncology rehab. So that's what I do, oncology rehab, as well as inpatient rehab over at the Emory Rehab Hospital. So for lymphedema management, we have compression sleeves. We have pneumatic compression devices that the patient would wear daily in the morning or in the afternoon. We have decongestive therapy where we have lymphedema therapists actually work to move the lymph fluid out of the extremities and back toward the heart. And then also strength training. Once they're cleared after surgery, even before surgery, ProHab is very important in developing good habits as well as muscle strength prior to a breast surgery because it helps recovery. Studies have shown that. But strength training guided is important. And so we have a partnership here with Emory with the Revital Cancer Rehab program with Select Medical, where they have a strength after breast cancer program where they provide more or less a cocktail of therapies for patients because the conditions are very predictable and the problems that they're going to experience are very predictable and well known. So neuropathic pain, our therapy team can do desensitization techniques, so gradually expose affected areas to various sensitizations to reduce the nerve hypersensitivity. There's manual therapy, soft tissue mobilization, aquatic therapy, lots of different pain management modalities, cryotherapy, TENS. Patients respond differently because the effect of the chemotherapies on their nerves vary patient to patient. There's a lot of overlap, but everyone still has a unique fingerprint on how they respond. And then also empowering the patient is probably one of the biggest things, education, self-management, and that's what we do. So from a pharmacological standpoint, we could prescribe gabapentin, pregabalin to reduce the neuropathy pain. We could even do SNRIs. That improves pain because it's also a neuromodulator, but it also helps with mood. I didn't list it, but cognitive behavior therapy is also very important because the perception is also very, very instrumental in the outcomes. And then there are topicals, capsaicin cream, so you can reduce substance P in the nerve fibers. Lidocaine patches, which our patient was wearing. Unfortunately, she had a dermatologic response, which was likely contributing to her lymphedema that she was developing in her left arm. And then we do nerve blocks, lots of injections, intercostal nerve blocks. We can target nerves most commonly injured during a mastectomy. And that provides some short-term pain. It can actually be diagnostic too. The serratus anterior plane blocks, thoracic paravertebral blocks, pectoralis and the erector spinae blocks. All of these are injections that we can perform to help alleviate the patient of pain. And one of the important things about doing that is also it helps to reduce the pain enough so that the patient can participate actively in therapy. And that's actually the biggest long-term benefit is control the pain acutely so that we can get the patient in therapy, get them into the Strength After Breast Cancer program, and so that they can be better equipped to manage their pain going forward because the pain returns. And then there's radio frequency ablation. We don't pull this, out of the hat early, but these are again other treatments that we can provide, especially if the patient is suspected at developing a neuroma. And then you have cryoneurolysis, so you could just freeze the intercostal brachial nerve, and that provides prolonged pain benefits. It can be months to years, but it really depends on the patient. And then it's minimally invasive, and patients typically recover pretty rapidly from it. So going back to our patient. So number one thing, she didn't need a steroid injection in her shoulder. She had post-breast surgery pain syndrome based on the history, based on the physical exam findings. History showed the reconstruction, silicone implants that had the capsular contraction. She had to have another surgery to do the deep flat revision. So on top of that, she had radiation to the chest wall. There was possible recurrence. Remember, she had the Horner syndrome, the pupil that was constricted. So CT finding around that same time did show that there was some soft tissue that might be compressing the brachial plexus, but we need to do an MRI to determine if that was recurrence or not. And the patient will continue to use the lidocaine patches as long as she could tolerate it, but she had to remove the adhesive strip around the patch that was causing her that inflammatory response. So she would place the patch, she would trim it with scissors and just place the patch on. And then we went to gabapentin 100 milligrams a day. We could titrate that up. I had her start the dose at night because it does cause drowsiness, and I wanted to see how she responded. And then I referred her to our breast cancer therapy program. And then she also had left upper extremity lymphedema. She said her arm felt heavy. Visually, I could see it was slightly larger. So it was stage 0-1-ish. She did have 14 lymph nodes removed. And she did have the axillary region treated with radiation. And she also cut her thumb while she was working, which she didn't know, but it was red, it was warm to touch. That was likely exacerbating her sudden onset of this swelling in her left arm. So start out simple, compression garment, 20 to 30 millimeters, and then also refer her to lymphedema therapy for complete decongestive therapy and a managed cording as well, because I did feel some palpable nodules in her axillary region. As she goes through the therapy, I was going to consider also a pneumatic compression device in the future. It's better to just prevent the lymphedema from becoming uncontrollable than to wait until it's significantly worse. She also had some shoulder pathology. One of the things I didn't mention was that she was a weightlifter prior to all of this. So she actually said she had an old shoulder injury, which made her think that, oh, I need a shoulder, a steroid injection. But the heaviness in the left arm, all the other treatments, most likely was the reason for it. So regardless, physical therapy was still going to be the best option for her. Now for the Horner syndrome, so now I'm concerned about, are we compressing the C8T1 sympathetic chain? That's nothing to do with the shoulder. Do we have recurrence? So she had a PET scan. PET scan did show, and it's very wordy, but she did have recurrence. She had significant lymphadenopathy throughout the cervical region, also abdominal region, and then also the mediastinal region. They did a biopsy, and it was also ER/PR positive, and that was just earlier this month. But her pain began uncontrollable. She started developing pleural effusions. Again, she had radiation that also included part of the lung, upper lobes of the lung, but she had recurrent significant lymphadenopathy. They had to drain almost a liter of fluid, which revealed malignant cells. So she's end stage, but she's at this point, her approach now is she's more spiritually grounded. She is recognizing that there's no treatment that will be curative. Another thing I didn't mention, she had a significant family history of cancer. So we connected her with palliative care to respect however she wanted to take the next journey. In the meantime, I'm here as well as the rest of the team to help manage her pain. So that's it for our patient. But I wanted to take this moment to mention that June is Cancer Rehab Month. So There's a website, cancerrehabfoundation.org. Check it. Maybe next week. It's launching soon. Organization I'm a part of, International Cancer Rehabilitation Foundation. They're trying to educate people domestically as well as around the world on how to care for our patients and our families, because everyone here more or less has been affected. At least most people have been affected in their family. But how to teach physicians how to care for cancer patients, how to address a lot of the complications from the treatment. So that is my time. Do we have any questions? All right. Thank you. Oh, yep. Oh, yes. Mm-hmm. Yes. Mm-hmm. Mm-hmm. Yep. Yep. I would say for breast cancer and all cancers at diagnosis, is always good to get rehab involved to start. You could get a baseline assessment of the patient before we start any treatment. And then B, especially if they're going to undergo surgeries and radiation, you actually improve their function and you give them a better platform to go through, the next portion of their treatment cycle. And then throughout, now there may be limitations in terms of like arm elevation and restrictions, and we work with the surgery team to follow those rules. And then there's wound care involved. So as a physiatrist, I'm also looking at wound care. So if we have radiation-induced dermatitis, I can help with, our team can help with managing that and getting them plugged into wound care. So like we offer comprehensive neuromuscular wound care, functional, and we're trying to keep the patient basically as functional as possible so they're independent. Yeah. Oh, yeah. Oh, she was up next. Yeah. You, yes. Thank you. Thank you. Yes. Yeah.
Like she declined for endocrine therapy.
She did. Yeah. Yeah, like September. I'm not September. Yes, sir. She was.
Like one of your first thoughts in a differential was that she could have metastatic disease.
Yeah, yeah.
But that didn't seem to come until later. And I guess my mindset would have been,
Mhm.
let's work her up for metastatic.
Yeah. So she was already seeing her oncologist, and that MRI that showed like something in the brachial plexus was done like the day before I saw her. So they were working in parallel, and I saw the results while we were in. I kind of reviewed them with her, and I was like, you still need to follow up with oncology, but I'll still evaluate your shoulder to see, do you have a true joint issue or is this something different? So coordinating, like looking through, the history and everything helped guide me to that. Yeah. Oh, yeah.
Thank you.
Yes. Yeah.
So, one of the major sort of viruses that we,
Mm-hmm. Yeah.
so I was curious if you were also looking at.
Yeah.
Curious if you were any other modalities
Mm-hmm.
that might be done. Gather within your area.
Yes.
Are we?
Yes. Yeah, and I actually didn't put it in here, but there are other modalities that are under experimentation, like transcutaneous stimulation, um, whether it's electrical or magnets. So there are other things being studied, but we could talk offline. But there are a lot, because that is a very, very known problem. That's really hard to address. Mhm. Oh, okay, so the question is, will you be able to review the ongoing clinical trials in this space, especially for therapy-induced neuropathic pain, which is a major long-term morbidity among survivors? It's kind of basically your question. Yes, yeah, yeah, yeah. No, yes. So the short answer is yes. And if you have any specific trials that you would like me to look at, because I see a lot of patients with neuropathic pain, not even just in the cancer space, but also stroke. But so yes, please reach out. But yes, we can, because we also have inpatient rehab as well as outpatient. And I work in both settings, and I have some other physiatrists who are also doing outpatient as well, treating cancer patients. So we all see neuropathic pain daily. It's really a tough problem to address. All right. Any more questions? All right. Well, thank you everyone for your attention and your time. Oh. Yes, yes. Thank you. Thank you. And I look forward to giving more talks, because we have head and neck cancer. We have so many other cancers, unfortunately, but at least with rehab, we try to address and keep the patient functional and going and part of the community, part of their family. Thank you.